Welcome to this CME CE certified activity titled Integrating the Latest Advances into Clinical Experience, Data and Expert Insights from the 2016 Meeting on Gastrointestinal Cancers in San Francisco. This educational activity is jointly provided by the Postgraduate Institute for Medicine and Access Medical Education and is supported by educational grants from Novartis Pharmaceuticals, Taiho Oncology Incorporated, and Lilly. My name is Dr. David Ilson, Professor of Medicine at Memorial Sloan Kettering Cancer Center and Weill Cornell Medical Center in New York, New York. My disclosures include consulting fees from Amgen and Eli Lilly. Our discussion today will include the most exciting and compelling data in gastric cancer from the 2016 Gastrointestinal Cancers Meeting and insights on how these clinical advances may be practice-changing. So let's begin. The first study I'd like to highlight is by Dr. Kang from Korea. This was a randomized, multi-center phase 3 trial of trastuzumab emtansine, or TDM1, versus a taxane in patients with previously treated HER2-positive metastatic gastric or GE junction cancer. The interest in TDM1 comes from breast cancer. We already know that in HER2-positive gastric cancer, first-line use of trastuzumab improves all outcomes. This study looked at second-line treatment in HER2-positive patients, comparing standard use of a taxane, either paclitaxel or docetaxel, with the new agent TDM1. The first phase of the study was to establish a dose of TDM1 to administer, and this dose was established as 2.4 milligram per kilogram. Then the study proceeded to the phase 3 portion, in which patients were randomized 2-to-1 to receive TDM1 versus standard taxane, either paclitaxel or docetaxel. The primary endpoint was overall survival. The patient disposition: patients more commonly received docetaxel versus paclitaxel on the control arm. The median duration of overall follow-up was comparable. Unfortunately, that there was no evidence of any improved survival for patients receiving the specifically HER2-targeted drug TDM1 compared to use of a taxane. So the primary endpoint of the trial was not met. Conclusions from this study include that the use of a HER2-targeted agent, TDM1, did not show any efficacy advantage over standard taxane therapy alone in the second-line treatment of HER2-positive gastric or GE junction cancers. TDM1 was well tolerated. These results are disappointing given the promising results for TDM1 in the second-line treatment in breast cancer. The next study I'd like to discuss is by Dr. Peter Enzinger. This was a multi-center, double-blind, placebo-controlled trial comparing first-line chemotherapy treatment with Folfox versus Folfox plus the VEGF-targeted agent zivaflibercept in patients with previously untreated esophagogastric adenocarcinoma. Patients were randomized 2-to-1 to receive standard Folfox or to receive Folfox plus the addition of zivaflibercept. The primary endpoint in this trial, which was treatment in the first line, was to improve 6-month progression-free survival. Unfortunately, the administration of zivaflibercept did not improve the primary endpoint. There was no difference in percentage of patients progression-free at 6 months, and this was comparable for the placebo arm versus the zivaflibercept arm. 1-year overall survival was also not significantly impacted upon. Response rates also appeared to be similar for the two treatment arms. But again, progression-free survival was not significantly changed with the addition of zivaflibercept to chemotherapy compared to chemotherapy alone. So conclusions from this study are that the addition of a VEGF-targeted agent, zivaflibercept, did not appear to improve outcome in the first-line treatment of gastroesophageal adenocarcinoma using Folfox. Therapy was generally well tolerated, although there were more episodes of hypertension, not surprisingly, in the zivaflibercept-treated patients. There was a potential indication of a benefit in patients that experienced grade 3 hypertension. However, this biomarker has not stood the test of time in other trials of VEGF-targeted agents. So this negative result adds to other negative trials of first-line VEGF-targeted agents in gastroesophageal cancer, including the trial of bevacizumab in first-line therapy, which did not improve outcome. We now, however, await the results of the global Rainfall trial, which is looking at the first-line use of the VEGFR2 targeted agent ramucirumab added to first-line chemotherapy. But unfortunately, this is, again, a negative result and is in line with the negative data also seen for bevacizumab. The next abstract I'd like to talk about is by Dr. Lee. This looked at an expansion cohort of patients treated with nivolumab monotherapy in patients with advanced or metastatic gastric or GE junction cancer. Patients received this anti-PD-1 agent, nivolumab, at a dose of 3 milligram per kilogram every 2 weeks. Many of these patients were heavily pretreated, and essentially this study was looking for a signal of activity, looking at objective response rate. If we look at the outcome, and I should mention also in this trial that there was no biomarker selection for patients. Patients did not have to have overexpression of a biomarker such as PD-L1. All patients were allowed entry regardless of their PD-L1 status. Of the 59 patients treated, a modest response rate was seen of 14%, including some partial and complete responses, and stable disease in another 20% of patients. The authors also looked retrospectively at PD-L1 expression, and it did appear that in the patients that had higher expression of PD-L1, there was a numerically higher response rate compared to low PD-L1 expressors. But the numbers on this trial are very small, and I should emphasize that even in the PD-L1 negative patients, there still was some signal of activity with a response rate of 12%. So I think there is an indication of some benefit for this agent, and this will need to be studied in larger sets and to establish whether or not a biomarker such as PD-L1 should be used to select patients. But again, the fact that responses were seen in PD-L1 negative patients indicates that this biomarker may not be mandatory. Conclusions from the study include that nivolumab was well tolerated and that a response rate was seen, modest, but a signal of activity, and that most of these patients had extensive prior therapy. The next abstract looks at another immunotherapy agent, pembrolizumab. These are data from the expansion cohort of patients treated with pembrolizumab who had either esophageal adenocarcinoma or squamous cancer. Patients, again, were mostly heavily pretreated and received pembrolizumab 10 milligram per kilogram once every 2 weeks. Again, this was a study, an expansion cohort looking for a signal of activity, and the primary endpoint was to look at response. An encouraging response rate of 30% was observed. Again, this is a very small number of patients. Most of the patients treated on this trial had squamous cancers, and only 5 patients had adenocarcinoma, but responses were seen in both subgroups. The waterfall plot showing that about 50% of patients had some measurable anti-tumor activity. Again, the number of adenocarcinomas was quite small, but there is a signal of activity here both in squamous cancers and adenocarcinoma. Now, unlike the nivolumab study that I just presented, biomarker selection was required on this study, with patients having to have at least a 1% positivity rate for PD-L1 expression in either the tumor or the stroma. So these were biomarker-selected patients, and again, a modest signal of activity was seen. So the authors concluded that an encouraging signal of activity, a 30% response rate, was seen, but again, remember that these are quite small numbers, and most of the patients had squamous cancers, and that about half of patients had some measurable degree of anti-tumor activity. The drug was well tolerated. So I think now we await results of larger expansion trials in this disease to see whether or not there is indeed a signal of activity. But I suspect that both this drug and nivolumab will move forward in further trials. Then the last abstract I'd like to discuss is by Dr. Lee. This was a trial also looking at PD-1 blockade, but specifically targeting patients with mismatch repair deficient gastrointestinal cancers other than colorectal cancer. So these were MSI-selected gastrointestinal non-colorectal cancers. The authors have previously published their results in MSI-high colon cancers indicating a significant signal of activity. Now they present data from the expansion cohort looking at non-colorectal cancers that were also MSI-high. And again, this study represents treatment of these patients with pembrolizumab that were MSI-high. Here we see a rather significant response rate of nearly 50% and another perhaps 20 to 30% who had stable disease, with an overall disease control rate of 76%. But a response rate of 50% in a population of patients with refractory GI cancers is quite remarkable. Conclusions from this study include that mismatch repair deficiency can be easily determined using commercially available tests. This can be by immunohistochemistry staining for the mismatch repair proteins or looking specifically for microsatellite instability testing. It appears that these data support their previously reported observations that MSI-high patients appear to be highly responsive to checkpoint blockade with anti-PD-1 therapy. And this was seen across tumor types. Patients treated on this trial had cholangiocarcinoma, stomach cancers, duodenal cancers, pancreas cancers, ampullary cancers, and bile duct cancers. So it appears that MSI-high status may be a strong biomarker for response to anti-PD-1 therapy. This is not surprising because MSI-high tumors have a high mutation burden, and tumors that have a high mutation burden probably present more antigens to the immune system and stimulate a better immune response. High mutation load also appears to correlate with response to immunotherapies in other cancers such as melanoma and lung cancer. So I think MSI testing in the era of immunotherapy, I think, is going to become more ubiquitous. We're going to start testing refractory solid tumors for MSI-high status, as these may be patients who are good candidates for later-line use of immunotherapy. The activity and often durable nature of these responses indicates that immunotherapy may be a promising new therapy for patients with MSI-high status. However, MSI is, unfortunately, in many cancers, relatively rare. In metastatic colon cancer, MSI-high only accounts for about 5% of tumors. In gastric cancer, it may be anywhere between 15 to 20% of patients that are hypermutated that are MSI-high. And in other cancers, the rate of MSI status may vary. But I think it's a clear signal that these agents appear to be active in MSI-high tumors and that further research is needed. Given the striking activity seen in late-line therapy, I suspect that use of these agents may move up to earlier-line treatment and potentially even adjuvant treatment in MSI-high tumors. So I think in conclusion, this was a very exciting meeting. I focused on discussion of new targeted agents and immunotherapy drugs. I think we've learned from the GI Symposium that, again, we have a negative trial of first-line VEGF-targeted agent in gastroesophageal adenocarcinoma with the addition of zivaflibercept not improving outcome compared to chemotherapy alone. We also have negative results for the second-line use of a HER2-targeted agent, TDM1, which appeared to be no better than taxane-based chemotherapy alone in the second-line treatment of HER2-positive esophagogastric cancer. We saw very promising results for anti-PD-1 therapy, including positive results for pembrolizumab in patients that were biomarkers selected for treatment, including a significant signal of activity in squamous cancer of the esophagus and significant activity in MSI-high non-colorectal GI cancers. For nivolumab, which did not use a biomarker selection, we saw modest activity in GE junction and esophageal adenocarcinomas with a suggestion of a higher response in patients that had higher expression of PD-L1. In the future, we will need to better refine selection of patients for immunotherapy trials and establish clearly whether or not biomarkers are needed and what are the optimal biomarkers. At this point, candidates for biomarkers include PD-L1 expression and MSI-high status. Again, it's a very exciting time with new developments of new agents and a lot of promise for the future. Thank you very much.